motto kind of is, no matter how you feel, get up, get dressed, and do your best.
A mom of five's routine mammogram led to a breast cancer diagnosis, and just weeks after celebrating the end of treatment, she faced another blow. Coming up today, how she found new strength and a new approach to health. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. When Tammy Sigurdsson Martinez went in for a routine checkup, she never expected to hear the word cancer. But her journey turned out to be one of courage, resilience, and family strength.
Tammy Sigurdsson Martinez settles into the chair as the steady drip of immunotherapy flows into her arm, the newest chapter in a journey she never expected to take.
When you first hear that you have cancer, it's like the bottom opens up underneath.
Doctors at the University of Kansas Cancer Center removed the cancer in 5 lymph nodes, followed by radiation. In November, she rang the bell, marking the end of treatment, but the celebration was short-lived. At that appointment, she asked her doctor to check a lump on her throat. Tests revealed melanoma, just 1 week after she was declared cancer-free.
I just celebrated last week, and then so it was rough to have to do it again.
Cancer runs in her family. Her mother had both breast cancer and melanoma as well. For years, Tammy says her own health took a back seat while she raised 5 kids as a single mom. Today, those children are grown, and her husband has 4 children as well. Despite a hectic life and double diagnosis, she felt confident with her cancer team at the University of Kansas Cancer Center.
The doctors are amazing. It's been I'm not going to say easy, but it's been a nice ride.
Through it all, Tammy's children and her husband, who never misses an appointment, have been her strength.
My motto kind of is, no matter how you feel, get up, get dressed, and do your best.
Tammy now makes her health a top priority, knowing her family depends on it.
We're so glad to have Tammy here with us this morning, along with Dr. Larry Corum, medical oncologist, and Dr. Kelly Rhodes-Stark, a radiation oncologist, both with the University of Kansas Cancer Center in Olathe. Glad to have all 3 of you reunited together.
Yes.
Here with us. Tammy, let's start with you. First of all, just how are you feeling today?
Great.
Great. Good to hear that. Where are you with your cancer treatments today?
I have 6 left, 6 more.
Sounds about right.
I think I have 6 or I'm pretty sure 6 more.
And what are those cancer treatments? Or you're doing those that we saw in the video? What are those treatments that you're doing?
Immunotherapy with Keytruda.
With the Keytruda. Dr. Rhodes-Stark, so Tammy's treatment for breast cancer included breast-conserving surgery. Explain how targeted radiation works. Why was this the best approach for her stage 1 cancer?
So I think that's a really important point, the way that you phrased that. So Tammy had breast-conserving surgery. So what that means is no mastectomy or removing the whole breast was needed for an early stage cancer. But when you have a lumpectomy, so you're just removing that portion of the breast where that cancer sits, most of the time sampling some lymph nodes, it's really kind of a package deal that you'll have some radiation to follow. And that is because there's a risk that cancer cells could be left behind, microscopic, and by adding radiation, which in most cases for breast cancer is going to be an external high-dose X-ray, so kind of like having an X-ray taken, that's going to markedly reduce the risk of cancer coming back. So you can target, and that's really important with radiation, you want to target the area where either cancer is sitting or potentially microscopic cells are left behind, and you want to spare tissue, normal tissue. So in Tammy's situation, with an early stage 1 breast cancer, 5 treatments, 5 X-ray treatments, localized just to that lumpectomy cavity, not having to treat the whole breast, it has really revolutionized treatment for stage 1 breast cancer.
That was really well explained. Thank you for that. Dr. Corum, when you saw Tammy at her breast cancer follow-up visit, you noticed the lymph nodes were swollen. What did you initially suspect when you saw her, just by looking at her?
Well, you might imagine that I suspected a recurrent breast cancer, given her recent diagnosis, but that wasn't the case. We knew the biology of her breast cancer was quite favorable. And we also know the way breast cancer typically behaves, and this didn't fit. You know, when I saw Tammy at that time, you know, the lymph nodes in her neck were quite large. You could actually see them sitting across the room, and they were quite bulky. It didn't make sense that this was recurrent breast cancer in that time frame. So I actually suspected a disease called lymphoma, which can result in enlargement in multiple lymph nodes. I actually thought she might have an aggressive lymphoma. So we were surprised to discover this was melanoma. It really wasn't on my short list at the time.
Interesting. And Tammy, what did you think it was at the time? This is kind of an interesting story.
I have a hyperthyroid, so I thought it was my thyroid going crazy.
Dr. Rhodes-Stark, Tammy had breast cancer and melanoma, and we learned that her mother did too, and you knew that at the time, correct? Is there a genetic connection there? I mean, it's...
You would think so, right?
Right, yeah.
I mean, so first of all, with Tammy's breast cancer diagnosis, which was shortly before the melanoma diagnosis, just the fact that her mom had breast cancer and melanoma at early age, she qualified for what we say is genetic testing. So sampling a tube of blood to see is there any mutation in the genes that predispose you to getting cancer, more so than the general public. And we did not find that in Tammy's case, which is interesting. But in general, most cancers are what we call sporadic. So they occur over time as we get older and our cells kind of get older and can't repair damage. And in this situation, we did not find that link.
Interesting. So her mother just happened to have breast cancer and melanoma, and she just happened to have breast cancer and melanoma.
And
there
you know what? Maybe in future years we will find that, and that's what keeps happening with this genetic testing.
You just
and
didn't
this
happen to
genomic.
find it.
We may not know what gene that has that link.
Gotcha.
That's what it is, because we keep expanding. So in the future, we'll still have her repository of her blood, and if that is found, then to be able to go back and know that for her family.
So there may be a link
there
down
may
the road.
Be. We just we don't know what it is right now.
Well, be sure to ask your questions. You can use the chat on YouTube or Facebook, or you can email the Medical News Network. That information is there on your screen. Tammy, you said that you're a very large family. Of course, your children, your husband have been your biggest strength. How have they kept you going through all this? Tell us all about them.
Well, my husband has never missed an appointment. Every single one, lab, surgery. So he's always there. And my kids, they all live far away, but they're always calling, saying, "Mom, go do it, do this, do that," you know. Make sure you're on it. And sometimes they would come during the surgeries while I'm recuperating, help me out.
And I want to make sure all your children are accounted for, because there are a lot. And we said that you raised 5 on your own.
I raised 5.
Your husband had 5, and then but then you had 3.
And then we have 2 adopted.
2 adopted. And so what's that like though, having that kind of support around you during this time? That just must be incredible.
It's what keeps me going. You know, those are my kids, so I have to smile. Yeah.
Yeah, I bet.
It's
I bet. Dr. Rhodes-Stark, how important is it to have that kind of support around a patient?
It's tremendous.
As they continue to recover.
Absolutely, it's tremendous. When you can see the difference in patients when they have that family or friend support, as versus when they're on their own or very limited support. Because as you can imagine, it's very emotionally draining, physically draining, going through this treatment. So and I can attest, her husband was in the room with her every time I saw her.
And we never want to watch anybody go through cancer alone, Dr. Coram, and we know there's lots of ways in the community that people can find support, right? Do you notice, though, when people have that support around them, that it just makes for a better patient when they leave their office and they're able to go home and have that support around them?
Of course. I mean, I think that's how we're built, right? We need other people, and family in particular. You know, unfortunately, we see patients from time to time who don't have that. and it's a much tougher experience in that setting. So Tammy's very blessed, and I think that's been a big part of why she's done as well as she has.
Well, it makes your job even that more important to make sure that you're that other side of the support, right?
Exactly. No, that's true.
So, Dr. Rhodes-Stark, for breast cancer patients, how important are routine mammograms? I mean, we can't stress it enough, and that follow-up imaging.
Absolutely. And so we know that screening mammograms are so important, but when you've had a diagnosis of breast cancer, typically you'll have your first mammograms after your treatment about 6 to 12 months after, and then you'll have annual routine screening mammograms. It's also important to have the physical exams with your oncologist to ensure that everything is as we would anticipate, and also knowing your breast density, because nowadays it may not be just mammograms, but patients may also require routine annual MRIs of the breast or ultrasounds.
Dr. Corum, Tammy received Keytruda, as we mentioned, before surgery to remove cancerous lymph nodes. How effective was her immunotherapy before the surgery?
Well, thankfully it was extremely effective. What we did in this case was we decided to give several doses of immunotherapy prior to surgery, and then a plan to give additional immunotherapy after surgery. When I saw Tammy after her first dose of immunotherapy, briefly, I wondered, what impact we were making, because the lymph nodes hadn't changed very much at that time. But then when I saw her after her second dose of immunotherapy, I think we were both quite happy about the fact that these lymph nodes were really diminishing. And then after the third and fourth dose, there was really nothing remaining that I could see or feel. So I knew she'd had a beautiful response. And it's terrific. We actually are seeing this with some frequency in this disease. Melanoma has a very unique biology, and immunotherapy has been an absolute game changer.
Dr. Rhodes-Stark, this cancer was caught early at stage 1. How significant is early detection when it comes to treatment outcomes?
Well, just in general for cancers, the earlier they're found, the better the chance that you're going to cure them. So stage 1, at 5 years, overall survival is 99 to 100%. So getting those screening mammograms, that's really going to be our best chance of getting detecting an early breast cancer before you can actually feel that. And then with each stage, as that advances, the prognosis is less favorable.
Makes sense. So Dr. Corum, what's the next step after the biopsy showed melanoma?
Well, the next step in this case, as it is with most cancers, is to understand the full extent of the problem, right? So we needed to do what we call staging. I mean, we knew she had trouble in the neck. We wanted to see if there were other sites of disease, so we did what's called a whole body PET scan. We also did an MRI of the brain. We know that melanoma has the potential to involve the brain. Thankfully, that was not the case here. The MRI looked beautiful. And the PET scan didn't really tell us anything beyond what we already knew, which was terrific, was that there was involvement in the neck, but we didn't see other sites of disease on the PET, which is exactly what we were hoping for. And we knew that plan of giving immunotherapy and doing surgery and additional immunotherapy had the potential to be curative.
So we think about chemotherapy when we think about cancer. Tammy received immunotherapy. So why did she receive some of this treatment before surgery? We kind of touched on this, but how effective is that approach?
Right. So there was actually a clinical trial, an important clinical trial that was published a few years ago, and one of our investigators at KU, Dr. Doolittle, as a melanoma specialist here, was a big contributor to that trial. And what that trial did is it took patients with locally advanced melanoma who could potentially have surgery, and it looked at the question of immunotherapy before surgery, and then surgery, additional immunotherapy, or surgery first, and then all of the immunotherapy after surgery. And what was discovered was that just giving a few doses of immunotherapy prior to surgery made a huge difference, and the outcomes were markedly improved. So the risk of having a recurrence in the years following was significantly reduced by giving just a few doses of immunotherapy before surgery. And I think what we've come to understand is that having an intact tumor and giving immunotherapy allows the immune system to see that tumor, to interact with that tumor, and to be stimulated in such a way to start eliminating that tumor in advance. But if you go to surgery first and take out 99% of the tumor, it's actually less favorable to give immunotherapy following surgery. So there is some advantage, it sounds strange, but there's some advantage to having that tumor in place and giving the immunotherapy up front. So that was a clinical trial that really changed our practice, and that's exactly what we based our treatment with Tammy on, knowing that that was the more favorable approach. So several doses before surgery, and then by the time she got to surgery, there was actually no remaining melanoma in those lymph nodes, which is amazing after only a few doses because these were quite bulky lymph nodes. And then we're finishing up, I think January is your final dose to complete the year of treatment.
And then she'll be complete?
She'll be done with immunotherapy, but we will continue to follow her. We will continue to monitor. I mean, things are going great, but you know, we know there's some potential for these things to survive in some cases, so we'll continue to follow her.
Keep monitoring. So explain the difference, though, for people, just the difference between what immunotherapy is doing inside the body and what chemotherapy is doing inside the body.
So I think when people think about cancer treatment, right, they always think chemotherapy,
Yes.
right, because that's what it's always been. And we still use chemotherapy for cancer therapy, but things are changing. Immunotherapy and oral targeted drugs and a variety of new treatments are making cancer treatment better and safer and more effective, actually. So traditional chemotherapy somewhat indiscriminately kills dividing cells, right? So that's good if you've got a cancer cell, but that's not so good if you've got a hair cell or a cell that lines your intestine or a bone marrow cell. Right, so I mean that's the problem with traditional chemotherapy. We kill some cancer cells, but we kill some normal cells as well. Immunotherapy is a way to stimulate the immune system. Many cancers have the ability to hide from the immune system, and those cancers can do that in many cases by expressing a protein called PD-L1. And when a cancer expresses the PD-L1 protein, it actually has a way of turning off the immune system. And sort of convincing the immune system that the tumor cell belongs there. But immunotherapy is what's called a immune blockade or immune checkpoint inhibitor, will block the interaction between that PD-L1 protein and the immune cell, allowing the immune cell to recognize the cancer cell for what it is, and revving up the immune system and then frequently eliminating those tumor cells.
So the immune system is lowered, but there might be higher side effects with the chemotherapy.
The immune system is heightened in the case of immunotherapy, but it can be suppressed with traditional chemotherapy.
What were your side effects, Tammy, if any?
Just tiredness sometimes, but basically that was it. I didn't really have very many symptoms after.
Well, that's good.
Do you remember anything? I don't know.
Is that pretty typical, Dr. Coram?
You know, I would say probably 40 to 50% of people roughly are going to get immunotherapy and have no side effects. It can be extremely well tolerated. You know, there's going to be another percentage of people, maybe 20 or 30%, who are going to have mild side effects. Maybe they've got a rash or some itching or those sorts of things. And then there's going to be a small subset of patients who are going to have some more significant problems. And those are primarily what we call autoimmune. So people have heard of autoimmune diseases like lupus or rheumatoid arthritis. In those diseases, the person's own immune system is the problem. You know, their own immune system is attacking their normal tissues. Well, by revving up the immune system with immunotherapy, in some cases, the immune system can get a little confused and attack the skin or the colon or certain endocrine organs. So we can see significant side effects in some cases, but for the most part, immunotherapy is well tolerated.
Dr. Rhodes-Stark, in Tammy's case and others, why are lumpectomies suggested rather than a total mastectomy? I mean, why take the risk of recurrence?
I think that's a wonderful question. That's a question we get every week in our breast clinic. And it's understandable. A woman has a biopsy, she's told she has breast cancer. It's a knee-jerk reaction. You think, okay, let's just remove the breast, I'll be cured, I'll be done. But if surgery alone cured breast cancer, we wouldn't have the need for chemotherapy, immunotherapy, hormone therapy, radiation therapy. So we've known for decades now that for early stage breast cancer, trials were done that showed that if you had the lumpectomy, sample lymph nodes, and add the radiation, your overall survival, meaning you're going to live just as long as you would as if you had a mastectomy, as well as what's called disease-free survival, meaning cancer is not going to come back. So if you're going to have the same outcome with less side effects, obviously with a small outpatient surgery as versus a mastectomy, then it's preferred to have the lesser surgery and the radiation.
Tammy, you celebrated the end of breast cancer, that you face another cancer diagnosis. Just hard to picture that, a celebratory moment followed by this news. How difficult was that emotional shift for you? How did you handle that?
It was, I mean, it's like I said, when you first hear it, you're like, I don't think I can say what I think, but
You can.
no, I would, in my mind, it would be like, oh hell no, not again, you know.
Sure. I bet.
But then, you know, you just start looking for the solution. What's the next step? What do I do? How do I go from here?
What advice do you have for someone facing it now who may be facing it down the road? Where do they find the strength that you have?
Just look for good things in your life. Mine is my kids and my grandbabies. You know, that's what is your light in their life? You know, and concentrate on that. That's what I do.
Find the good. Find the good. Dr. Coram, Tammy's mother had breast cancer and melanoma. We talked about that. Passed away from it. When you know this family history, how does that shape the level of surveillance that's provided? Dr. Rhodes-Stark talked about doing the genetic testing and did not find that connection. But does that change the surveillance?
Well, I mean, family history is obviously very, very important. Genetic testing is very important in many cases. But honestly, in terms of the treatment of an individual and the surveillance of an individual, it really comes down to the biology of that particular tumor. And so, again, the family history is important, but it doesn't necessarily influence the way that I would follow an individual person with their disease. Because even within melanoma or even within breast cancer, those diseases can be quite different from one individual to another. And it has to do with the certain molecular findings. Melanoma, we know, can express certain mutations, and so we have to be aware of those things, and that can change even if there's a family history. So you really have to look at the individual in that case, if that makes sense.
It does. Let's get to some questions from our viewers because we've got some good ones. Jeremy asked, are there cancers more likely to pop up after you've already had cancers once before, like this one?
You know, in general, if you say cancer survivors, what's the likelihood, not talking about recurrence of that cancer, but talking about a second cancer. And so the longer that we live, the higher likelihood that we're going to get some cancer ourselves, right? Because we know breast cancer, 1 in 8 women. We know prostate cancer, about 1 in 7 men. So the longer we live surviving the one, we do. And on average, it's about 10%, 12% of cancer survivors will have a second cancer.
Dr. Coram, why was melanoma not on your short list with Tammy? Why did that surprise you? I'm just curious.
Melanoma is a strange disease. You know, melanoma often surprises us. It does odd things. You know, I would say, you know, many cancers are somewhat more predictable in their behavior and in their pattern of presentation. I mean, if I'd been asked to make a list of 10 things that this could have been, melanoma would have been on the list, but it would have been further down.
Further down, okay.
I mean, of course, we thought, you know, could this be her breast cancer? But the most common cause of rapidly enlarging lymph nodes is going to be lymphoma, which is what we thought here. So, but that's why we do a biopsy, right? Because we never guess, we never assume that we know. And the tissue is critical.
Tom is asking, what is the difference between radiation and chemotherapy?
Very different. That's a good question. So different methods of treating cancer. So radiation in general, in most cases, is using high-dose x-rays that you want to target very carefully to that cancer site or areas that could harbor small microscopic areas of cancer. So we're using techniques such as advanced imaging to ensure that we're treating with these high-dose x-rays. Typically, patients come in and out of a department, outpatient treatment. You don't feel the treatment, you don't see the treatment. You're in and out in about 15 minutes, and the treatment on average might be 2-3 minutes. But that can go on daily, Monday through Friday, for weeks at a time. Whereas chemotherapy, traditional chemotherapy, is typically more of an IV drug. That we think that, as Dr. Coram so eloquently explained previously, is that that's going through the body, right? And it's attacking different cells. Whereas radiation, most of those side effects are going to be in the area that we're treating.
Rick is wondering if stress or lifestyle can play a role in cancer coming back.
You know, that has been studied extensively, and what I would say is that we've not been able to say that there is a direct cause. So what I mean by that is, we know that smoking, that can be a direct causation for lung cancer or certain cancers in our mouth and throat. But is there an indirect influence in our body, in our immune system, in inflammation and such? And so I think that we still have more to learn. We know it's not direct, but potentially could have some indirect effect on our body's ability to kind of fight off our cancer cells.
Tammy, have you made any lifestyle adjustments since your diagnosis?
I think the main one that I've done is put my health as a priority, because raising the kids, I'd say, oh, my head hurts, oh, I'll deal with it later, and just keep going. So I think I found that you have to put your health, because you're no good if you're not healthy.
Good. Getting rest that you need and putting yourself first. I love that. Well, as we've discussed this morning, it's important to get your mammogram annually. Scheduling it on or near the same date annually helps make sure you don't let a year or two slip by without making an appointment. To schedule your mammogram, simply go to healthsystem.com/breast imaging, and you can answer a few questions before scheduling your next mammogram. And skin checks are just as important. When you're checking your skin at home, remember these 3 words: new, changing, and unusual. Take note of any new moles or blemishes. Always check if your spots are changing in color, size, shape, or texture. And be vigilant with any spots that have any unusual outline or that are constantly itching or hurting. If you do see something concerning, do not delay in asking your doctor or dermatologist about it. Tammy, what do you want people to take away from your personal story today?
There's always hope. There's always hope.
Always hope. That's...
Do what your doctors say, because results are better.
Listen to your doctor. I think both of these doctors appreciate you saying that for sure. Dr. Rose Stark, what's the big takeaway today?
Get your screening mammograms, earlier detection, higher rate of cure, same thing with your skin checks. Basically know your body, right? And notify someone immediately if you have any concerns.
Thank you for your insight today. Dr. Coram, wrap us up on this Friday. What's the big takeaway?
Well, cancer therapy is changing. I always say this, education is critically important. I think many people come into the clinic with preconceived ideas about what's available or what treatment's going to look like. And it really helps to sit down and have the opportunity to be educated on things that have changed, because the last decade or more in cancer therapy has been amazing. Many new targeted treatments, many improvements, and things are getting better, and treatments are becoming less toxic and less difficult. So I would encourage people to stay open-minded. If you have something that's making you nervous, sit down and talk with someone who may have information that you don't have.
Yeah, Great advice. Always great to have you on the show. Thank you to all of our guests today. Thank you so much. Thanks to our guests for being with us. Thanks to our viewers for being with us. Have a great weekend, and we'll see you back here next time. Coming up Monday on the Morning Medical Update, the president of the Kansas City Current is sharing her breast cancer diagnosis and why early detection is so important. I'm Jessica Lovell on the next Morning Medical Update. Raven Jemison, a leader on and off the soccer field. Her message for all women, Monday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.